So for the sake of the recording this morning, I'll just say welcome to the Public Health Council Partner Meeting for March 2023. And we're going to be hearing from a number of our substance misuse partners in the region this morning. And right now we're going to hear from Andrea Smith and Lauren Chambers from All Together.
Thanks, Alice, and thank you for this opportunity to allow us to talk about our role within the Public Health Network and how our work addresses the Public Health Council's Community Health Improvement Plan. My name is Andrea Smith. I'm the Substance Misuse Prevention Coordinator, and I'm here with my colleague Lauren Chambers, who is a Continuum of Care Facilitator, and we serve as staff of the Upper Valley's Regional Public Health Network. So before we dive into the work plan strategies that we're working towards, I wanted to give a little bit of background about the Regional Public Health Network and how we tie into the Public Health Council. And we recognize that for some, this might be a refresher. You may know all about that, but I know that we have some new faces that have joined this group over the past handful of months. So I just want to make sure everybody's caught up to speed on that. So New Hampshire has 13 regional public health networks, and in the Upper Valley and on the New Hampshire side, we cover about 11 towns and 1 city. And each regional public health network works to address complex health issues by bringing together people from a variety of sectors to integrate multiple public health initiatives and services into a common network of community stakeholders. One of those public health initiatives includes a focus on increasing awareness and access of substance misuse prevention, treatment, and recovery services, which is what Lauren and I specifically focus on in our work. So each regional public health network coordinates a public health advisory council, or a FAC, as what we call it. And the role of the FAC is to advise the regional public health network partners by identifying regional health priorities based on assessments of community health, guiding the implementation of programs, practices, and policies that are evidence-based to meet these improved health outcomes, excuse me. So in the Upper Valley, our health network contracts out the Public Health Advisory Council work to the Public Health Council of the Upper Valley. And each regional public health network has a substance misuse work group, and ours is called All Together, which is the region's Substance Misuse and Suicide Prevention Coalition of the Upper Valley. So on these meetings, when Lauren and I share updates, you'll often hear us referring to All Together. All Together is holding this training, something like that. So that just gives you a little bit of background. So as Alice has worked to create the Community Health Improvement Plan, we wanted to share how our work at the RPHN aligns with the goals of this CHIP. So you'll see here, this is just a snapshot of the draft section from the CHIP that Alice has shown us over the past few months for alcohol and drug misuse prevention, treatment, and recovery. I do want to call attention to the indicator on the far left that talks about drug poisoning deaths. You'll notice over the past few years as concerns over fentanyl has been at the forefront of many people's minds, but specifically those in the field of substance use, you'll see that the language has started to shift from overdose to drug poisoning. And on the right-hand side, you'll see the 4 categories that I think Alice has throughout all of the main parts of the CHIP. So collaboration and service improvement, education, advocacy, and health equity, and then a number of different strategies below each one of those. So what Lauren and I have done is we've pulled the strategies out, and we're going to share how these strategies, again, align with our combined state work plan that the 2 of us have developed for the next 2 years. And we've placed each strategy into where it most appropriately falls along the continuum of prevention, harm reduction, treatment, and recovery. So as you'll hear our other colleague, Maggie, talk about in just a little bit, she's going to reiterate that we use the strategic prevention framework to help guide our strategic planning to addressing substance misuse in the region. So 2 parts of that framework are assessment and capacity. So a few of the strategies listed in the CHIP, they don't really fall clearly under the continuum, but they do relate to this framework. So the first one is implementing recommendations from the 2022 Coalition Capacity Assessment. That's the first strategy. So what we do is we will continue to work with the Public Health Council to implement recommendations with an All Together. And All Together also conducts our own assessments throughout the year, such as a community survey, which is a way for us to gather information from adults in the region on their perception of youth, substance use, and mental health. We conduct focus groups and listening sessions, and we're continuously conducting key stakeholder interviews across the various sectors to not only increase engagement, but to evaluate capacity and to also gather qualitative data. And then we also work with our evaluation provider for best practices and support throughout. Another strategy from the CHIP is to conduct qualitative needs assessments with the support of members of marginalized groups to identify health disparities and opportunities to address them. We try to look for ways to cross-tabulate data by different demographics, and this really allows us to keep an eye on emerging or concerning trends. So for example, from the Youth Risk Behavior Survey data from 2019, because we don't have the 2021 data for Vermont yet, the state of Vermont found that students who identify as LGBT who currently drink alcohol are significantly more likely than heterosexual or cisgender students to drink on 10 or more days. So again, that's some important information that we can pull out that can help us specifically create activities or strategies or implement plans to address those specific needs. We also aim to involve key stakeholders throughout the process, so people with lived experience and perspectives. We really try to take on the approach of nothing about us without us. So you'll see our other colleague, Hannah, is on the call. She joined our team to specifically focus on youth engagement and finding ways to help get youth to guide and direct our prevention efforts in the region. And we try to learn from populations the best way to reach them rather than using blanket approaches. And finally, the last strategy that relates to this framework, the increased capacity of grassroots and small organizations representing people with lived experience of health inequities to address the concerns of their communities independently through grant making and technical assistance. So you'll see over on the right-hand side, we refer to it as the flower, the Strategic Prevention Framework flower. You'll see that sustainability and cultural competence really are at the core of this framework. So we are always keeping these two things in mind when we're planning our strategies. And so one thing, as we've done sustainability planning for our All Together Coalition over the past year, one thing that we have learned is that we are strong at connecting people with resources and opportunities. So while we can't necessarily provide the funds through grant making, we can assist with grant applications. We can provide technical assistance in bringing various trainings to the region or assisting organizations in building the infrastructure of their small organization. And so using that strategic prevention framework, we're actually embarking on a new strategic plan for years 2024 through 2027. I think, Lauren, correct me if that's wrong. So stay tuned for that over the next year. But now Lauren's going to go through the other strategies, again, with examples of where they most appropriately fall within the continuum.
Thanks, Andrea. All right, so getting into sort of our buckets of work across the continuum of care. So we spend a lot of time in prevention supporting several strategies. One that you may be familiar with is the annual Drug Take Back Day, which happens twice a year in April and October. So we partner with local police departments, senior housing buildings, and other local businesses to collect expired, unused, and unwanted medications for safe disposal. And typically with each of these events, we collect between 500 and 750 pounds of medication at each time. So it's a great initiative that happens across the country on those 2 days in April and October. For the legislative breakfast that the Public Health Council hosts every 2 years, we work with Alice and other partners to support making connections to subject matter experts and convening community voices to bring all perspectives to the table and help to facilitate at those meetings some of the important conversations around policy changes. And then Andrea is also working very closely with Alice and the Public Health Council, supporting a grant from the New Hampshire Charitable Foundation, which really is helping to sort of expand the advocacy work that we can do in the area, because that's something historically that we have not been able to do due to federal funding restrictions. So there's a lot of great work going on around that. We're also constantly sharing information about substance misuse trends, what's going on in the community and what's going on with policy in both states. So again, the work through the advocacy grant is really supporting this and helping to bring in different community voices and support those who want to share their stories and share what a policy change might mean for them, how it might impact them. So we also did a lot of work around the YRBS last year when it was potentially going to be changed to an opt-out survey. Did I get that right? It's currently an opt-out. Okay, it was going to be changed to an opt-in. I got it wrong. We did not want it to be changed to an opt-in because that would severely reduce the amount of students that would take the survey, and it would just really affect the really quality data that we get from it. So we are happy to say that it remained unchanged and is still being administered to all students unless they want to opt out. So we share some of those information updates and what's going on through the newsletter and then through the grant, as I mentioned. Additionally, in the realm of prevention, we do a lot of work, again, with the YRBS. So we really look to that to help us plan our strategies. We then share that information back with communities and with different stakeholders. So we can provide that kind of support by reviewing the data year by year, looking at trends, sort of breaking it down into digestible and easy to understand graphs and snippets, and we can present that to schools or to the general public. So that's something that we also can support with and are getting ready to do that very soon with the 2021 data when it's ready. We also just recently partnered with Up for Learning from Vermont to bring the Getting to Why program to 2 schools, Andrea, in the Upper Valley. Is that right? 2? Yeah, 2 schools, 2 districts in the Upper Valley. So if you're not familiar with the Getting to Why program, this is a program that really empowers the students to review their own school's YRBS data, select a problem or an issue that they feel is important to them and that they want to work on. They'll actually hold a data retreat where they will sort of comb through the data, decide on what they want to work on, and then they'll choose a project to work on either in their school or in their community that they hope will make an impact on whatever the measure or the indicator is that they're hoping to change. So if it's related to substance use, if there's a high rate of binge drinking, students may choose to focus on that and choose some kind of project or activity around reducing binge drinking. So we're really excited to be doing that with 2 schools in the Upper Valley. It's going really well. And then also Andrea and I and several other team members in the RPHN are also Connect suicide prevention and postvention trainers, as well as youth mental health first aid trainers. So we can provide those trainings as needed. And we oftentimes get requests by school districts to opt to host Connect suicide prevention trainings as it's a requirement of school staff to be trained in suicide prevention every year. So moving into harm reduction, I do a lot of this different harm reduction work recently with more overdose prevention funding from the state. So I'll just go through some of the things that I've been focusing on a lot lately. So obviously we do a lot of community trainings. We've been happy to start hosting in-person community Narcan trainings again starting last summer. It was something that sort of was put on hold with the pandemic, but we've been doing a lot recently, and they've been very well attended, and we've been able to get these great resources and supplies out to people who need them. So we have trainings open to the public, and then we also will host Narcan trainings or overdose prevention trainings to anyone who requests them, really, whether it's a business or an employer or another community organization. Or schools. I get a lot of requests from schools, nurses especially. So we will come and train whoever is interested. Also disseminating lots of information about harm reduction and trends that are going on in our area. So we obviously share, written material when we table and do trainings, but we also bring those harm reduction supplies. So we bring Narcan, we'll bring doTERRA bags, which deactivates medications. We'll bring fentanyl test strips, CPR mask, keychains, again, as well as the written material. And then another initiative that we've been working on recently is installing the LOX boxes, which is the lower picture there. We've been trying to put those in public spaces where the general public might be, And the concept is very similar to like an AED, just having this life-saving tool available if something were to happen. So we have so far installed 2 in the Upper Valley and 5 in Greater Sullivan County. I serve both regions, so 7 is my total. But the box there has 1 kit of Narcan in it, which has 2 doses, and then some breathing, some rescue breathing tools. So we've been working on spreading those, the awareness of those being available and installing those in places that are interested.
I'm sorry to break in, Lauren. Pretty much out of time. Do you have much more?
I just have 2 more slides, but I can go really quickly. I'm sorry. Do you want me to continue? Okay. So just as far as for treatment, this is not necessarily an altogether strategy, but DHMC does employ 1 full-time recovery coach in the ED, which is an important resource because folks coming through there can then get connected to, and she can help with resource navigation. So it's a real asset. And then also the Lebanon doorway. So I help organizations get connected to the doorway, whether it's just making them aware of their services, getting them Narcan if they want Narcan. That happens a lot as well. And increasing access to medication-assisted treatment programs. And then I know the MAP team has recently updated the treatment guide, which is the picture here, which is great. And then we also created a small pocket card specifically for first responders on some of the local treatment resources. And then for recovery, we work with the Recovery Friendly Workplace Initiative to try and recruit new businesses to join and be designated. We have, I think we have 5 or 6 maybe in the Upper Valley, so definitely looking for more. We host a series of recovery coach trainings about once a year when we have extra funding and when we can pull it off, which are very well attended. They usually sell out, although it's free. So it gets filled up. And then we work a lot around stigma reduction. So we have done some work in the ED at DH. We've designed these recovery ally pins, which we're encouraging employees to take a pledge to say that they will practice using appropriate language and non-stigmatizing treatment of patients. And we also do a lot around Mental Health Awareness Month and Recovery Month in September. That is all I had.
Great, thank you.
Sorry for going over.
No, it's great information, and it's just hard to get it all into a short period of time. So if folks have questions for Lauren and Andrea, please feel free to put them in the chat, and maybe we'll come back in a little bit for an opportunity to do some Q&A. And now I'd like to turn it over to Maggie Coleman.
Hi, everyone.
Talk about vaping.
Great. I'll pull up my screen. Can everyone see that okay? Great. All right. So in the next couple minutes, I'm just going to talk to you a little bit about some of the youth vaping specific efforts we've been doing at DH with population and community health. All right, so here's where we're headed, kind of a robust agenda for just the next couple minutes, but I want to talk a little bit about the strategy that informed this toolkit of resources that we've created. As Andrea and Lauren talked about, 2 frameworks kind of informed the strategy behind this piece. The first of which is that same SAMHSA 5-step strategic prevention framework that was kind of the compass behind it. Andrea touched a little bit on some of the steps within there: assessment, capacity, planning, implementation, and evaluation. Basically, I use this framework to leverage some of the existing resources and evidence-based interventions around youth vaping and vaping education, and then kind of throughout the process, self-evaluate, tweaks and things, make sure we're reaching the right people. And then the second framework is the Lean Six Sigma kind of continuous improvement process. So for those unfamiliar, that process kind of focuses on eliminating waste from systems and creating value with the lean piece, and then focuses on reducing variation in processes and removing defects with the Six Sigma piece. So at DH, we combine these 2 QI approaches and leverage the benefits of both in this, similar to the SPF framework, a 5-step iterative continuous improvement process in which you define, measure, analyze, improve, and control improvement work. So the assessment of the current kind of environment around youth vaping and capacity available involved a community survey to kind of do a pulse check, a review of national state and eventually local YRBS data, though we're waiting on some of that information still, around some of the risk behaviors that are vaping specific, and then also research of existing curriculum for youth around vaping. And then putting that all together, we created this toolkit, which we'll kind of walk through. The goal here was to create kind of a one-stop shop with resources for both health professionals and educators, and then also sort of a more lay audience, so resources for students and caregivers. And we're still in the process of distributing it and designing some kind of community engagement efforts around it to get everyone on board with some of the best practices included. So we'll talk about that as well. So for the assessment piece, hearing directly from stakeholders was definitely a priority. We borrowed heavily from Mount Ascutney's vaping assessment survey that they created, and we developed it in Qualtrics with the whole substance misuse team's feedback. We were looking to understand some of the existing curricula around vaping in classrooms, how, by whom, when it's delivered, educators and administrators' feelings about the adequacy of the current efforts, and then thoughts on alternative to suspension policies when students are caught vaping. We distributed it with help from the substance misuse team at DH and our emergency preparedness team, and got 16 respondents from 13 unique schools in the course of just a couple weeks. So we got some great information from this survey. Some of the de-identified results are on the right there. I'll go into a couple more in detail in the next slides, but these are some of the highlights. So one question was just, how many times are students receiving vaping education throughout their school career? And just at quick glance, you can see there's a lot of variety here. You know, some are getting it once every grade, 5th through 8th grade, some are getting it starting in 6th grade, and some are getting it once in 8th grade health, or this is the first year they've had a class with vaping addressed, or just one time. So clearly there's a lot of variation in the prevention education in schools, and this kind of reaffirmed the need to support our community partners in aligning with best practices around vaping prevention. Think about this slide as we move to the next question, which was, how do you feel about the amount of time spent on vaping education at your school? The majority thought too little, a little less than half thought just right. So this kind of in conjunction with these responses, again, just affirm the need for a little bit better alignment to best practices and figuring out what the right amount of good education would be. So now we arrive at the creation of this toolkit. With that assessment and capacity stage of the strategic prevention framework complete, it was time to begin planning and supporting implementation of some interventions around youth vaping. So again, this toolkit was meant to be a one-stop shop, which was informed by the survey results from our community. So it has a couple kind of main sections, the first of which provides an overview of data trends, some of the health outcomes of vaping, and some of the marketing appeals to youth that we're seeing lately. And then again, there's these two kind of audience sections. So the first of which is resources for educators and health professionals. The second of which is resources for caregivers and students. And then I'll talk a little bit about the initial distribution efforts and where we're hoping to go, but I'm hoping this call can present some additional opportunities to get this resource out into the community. So feel free to hit me up in the chat if you have ideas for that. The overview of data trends, health outcomes, and appeals to youth. This is a screenshot from the toolkit. This section dives a little more deeply into some of the data from the 2022 National Youth Tobacco Survey, as well as some trends about revenues from taxes and some of the regulation around tobacco products, as well as nicotine in vapes. So there's kind of some data heavy portions there. And then also some of the information about the thousands of flavors that are now available and can be particularly enticing to youth. So that kind of overview section has some of those pieces. The second section is where we have resources for educators and other health professionals. So along with the substance misuse team at DH, I reviewed an array of evidence-based and evidence-informed curricula for both middle and high school settings, and have some recommendations of neatly packaged, easy to implement curriculum, short form activities, so worksheets, discussion guides, virtual field trips, animated games, interactive quizzes, was basically looking to include a really big variety of resources for the classroom that vary in terms of both facilitator training required, length of the modules, delivery formats, target audience, wanting to just provide as much evidence-informed and evidence-based material as we could in one spot. There are also alternative to suspension programs in curricula. So when students are caught vaping, recent studies suggest that these kind of alternative to suspension policies can be more effective at actually helping students stop using tobacco products as opposed to suspension, which is isolating, doesn't address the root cause of vape use. So these programs include some peer support, reflection into individuals' motivations behind their vape use, and then some resilience building and coping strategies. So there are a couple examples of those in the toolkit as well. There's also printable materials for classrooms and other youth-facing spaces. So posters, fact sheets like this one. Those are some of the resources in that educator and health professional audience piece. And then in terms of resources for caregivers and students, this portion of the toolkit involves kind of a vaping 101 section. So it has information on nicotine's impact on the developing brain, photos of vapes and how easily they can be concealed. We have had some feedback from educators and parents about just wanting to know what these things actually look like. And it is this trend now, they're becoming smaller, you know, more appealing in their design, easy to hide. So having some real photos of vapes in there was important to us. There are also some fact sheets, videos, and webinars targeted at more of a lay audience. A lot of them are parent facing, but there are some student, kind of student focused fact sheets as well. And then this section also includes self-guided, evidence-based cessation resources for youth. So for middle schoolers, high schoolers who are looking to stop their use of vapes, there are some anonymous resources like My Life, My Quit, which is being promoted by the state of New Hampshire right now. That's a totally anonymous text-based resource that involves some coaching and regular reminders, inspires students to set a quit date and work toward it. So those kind of resources are in this section of the toolkit as well. In terms of distribution, so we're working to get this out into the community. We did directly send it to all of the recipients of the initial survey. So all of those schools and partners received the toolkit. It's also currently being hosted on the UV Altogether website and the Greater Sullivan County Public Health Network website. It's also been shared with a couple similarly focused prevention work groups in Vermont. And then I'll be sharing information that's in the toolkit at some school and community-based events at some of our school partners and libraries as well. And in general, we're just looking to get this resource out there. So if folks have any immediate thoughts about people who should be receiving an email with this toolkit in it, please let me know. We're also marketing the My Life, My Quit cessation resource with social media marketing in a kind of pre-built campaign that was shared with us by the rescue agency, and then also promoting that cessation resource through a vaping prevention link on the Altogether website using some Instagram, Facebook, and other social media marketing. We're also on some local and streaming radio ads as well. So you might be hearing it when you tune in your own car in the morning. So that's kind of a rapid fire overview of what is in this toolkit. Thank you for allowing me to present it to you all. And please feel free to reach out with, again, any ideas for reaching more folks with this material. I'm happy to share these slides with you, Alice, after, and I'll post a link to the toolkit itself in the chat. You can download it, print it, or just view it with that link. Thank you.
Great, thank you. I do see a question from Anna. We'll come back to that later if you don't mind. I've promised Kate Stokes that she can get started now. So thank you very much for that, Maggie. And also, I think, Maggie, have I spoken with you about the possibility of sort of putting that up on as a blog on the PHC website so that we can just keep it out there so people can find it?
Sounds good. Thank you, Alice.
Right. Kate, thank you for joining us to talk about weaving the safety net. I just want to confirm with you, because you joined us a little late, that we are recording, and want to make sure that that's okay with you. If not, we can pause the recording.
No problem. That's fine with me. I
Great,
just have a
thank
little
you.
disclaimer to everybody that I'm homesick with COVID, so I will do my best. I feel a little foggy today, but I made it 3 years without getting COVID, so figure it's my turn. Okay, thanks for having me here. I'm going to talk about this federally funded project called Weaving the Safety Net. And let's see if my slides will advance. Oh, there we go. Okay. So this project is funded by HRSA, and the goals of the project are to repair gaps in the system of care for rural families impacted by substance use. The target population is really pregnant and postpartum people with substance use and their families. And we have a consortium. The Public Health Council of the Upper Valley is one of our consortium partners, as well as the HIV and Hepatitis C Resource Center, the New Hampshire Area Health Education Center, and the Early Care and Education Association, and Dartmouth Health. So this is a 3-year project, and we are currently in year 2. So in terms of why this project exists, it's really stems out of the real prevalence of substance use among babies born at DHMC, and the fact that maternal death in the United States and in New Hampshire are still largely due to opioid overdose and suicide. So we're working to meet the needs of this population. So we really strive in this project to make sure that we're including the voice of people in the community, people with lived experience of substance use. And sorry, my slides are advancing funny. To start out with this project, we did a lot of interviews with different stakeholders. So we looked at people we talked with people in the community with lived experience. We spoke with early childhood educators. We spoke with EMS providers, and the idea of the safety net is really looking at out in the community, where are people coming into contact with different touch points, and how can we make it so people feel more comfortable and so that systems are working for them. So we did a bunch of interviews to try to figure out where the needs were and what kind of education we could provide. What we found is that people experience stigma from the health system and community-based service providers, and that there's really still quite a bit of need for education about addiction, about treatment for addiction, about recovery for all different kinds of roles. So in terms of response, for the EMS providers, the interviews that we did with them, we have come up with harm reduction bags. So we found that they, when they respond to calls involving substance use, it's quite hard. They have a limited amount of time. There's a lot going on. They wish that they had a social worker riding with them to help with follow-up, because they end up responding repeatedly to the same location. So we came up with harm reduction bags that have naloxone in them. They previously had fentanyl test strips in them, but we're holding on that for now as they're being considered drug paraphernalia in New Hampshire at the moment, hoping that that changes. And there's a lot of information about resources in the community, and so that people have access, because what we heard is that when people were looking for help and feeling ready to seek treatment for their substance use, they had a really difficult time knowing where to go. So these are harm reduction bags that we put together, and they have information from our consortium partners in them. For healthcare providers, from the interviews that we did with healthcare providers, we heard a need for more training around more education around addiction and addiction treatment. And we have put together a video that is almost ready about recovery-friendly perinatal care. And it's kind of an anti-stigma video. It's a brief video that we'll plan to use as part of a training with staff. So kind of a discussion to help start a discussion. We also, so that's that video, and that addresses recovery-friendly language, appropriate language, and the importance of that, and also talks about addiction as a medical condition. We also put together a training for inpatient staff about screening for perinatal patients and how important it is to make sure that we're screening people for substance use so we can help anyone who's interested get into treatment. And we came up with an abbreviated version of motivational interviewing for inpatient staff. To address the needs of childcare providers, we came up with an ECHO, which we just completed last week, called We Are All in This Together. And this really addressed trauma-informed care. It addressed how people can approach families and reduce stigma and make sure that we're helping people connect to services. So we'll be following up with those childcare providers. This was the ECHO, and these were the topics of the ECHO, and we had good attendance. And then from the community experts, from those interviews, they talked about the stigma that they continue to experience when seeking care, and in different places, you know, the challenges of logistics, our rural community, and the need for information about services to be easily available so that people have access to that when they're ready. We also put together a video about hepatitis C treatment and hepatitis C in pregnancy to help get people into treatment, into this new, easier version. We have a video and a brochure about that. And this is the brochure. We also have, this is good for everyone to know, for anybody who's interacting with people who have substance use and are pregnant. We created a helpline, and this is the helpline brochure. So this is a phone number. It is business hours, but it's a number that somebody can call and get connected directly to a community health worker. And then that community health worker can connect them directly to a provider that day, so that they're really getting supportive care. And that provider specializes in obstetrics and addiction medicine. We got feedback that it would be great if this could also be a texting, because this generation really likes texting and prefers that. So that'll be our next piece to try to figure out. We also do provide free cell phones and free monthly data cards for people who are pregnant and have substance use, and that goes, we can do it until 1 year through 1 year postpartum. So that's another piece, and that connects people so we can help with all those logistic challenges, and they can connect with their provider that way and do telehealth. And that's just a bit about how that helpline works. We put together about reproductive care and the supports that are available around that. People can use the helpline to seek care for reproductive health care. So that's the project in a nutshell at the moment. If there's any questions, feel free to reach out.
Thank you, Kate. That was terrific. I've just received word that the snowstorm, despite being on Saturday, messed up schedules for folks at Mount Escutney Hospital. So Melanie Sheehan is out taking care of the Veggie Van Go van and cannot join us. Alice Stewart may join us a little bit later to talk about what's happening at Mount Escutney. If she's not able to, I have the slides and I can share it with you, but it would be much better if someone from Mount Escutney is able to do that. So that being said, it's 9:45 and we have a few minutes. So now is a great time for questions and comments and additions to the information that's been provided so far by Andrea, Lauren, Maggie, and Kate. So let's see, I see, Emily, do you actually want to touch base on some of the work that Hartford Community Coalition's been doing? I see you have something in the chat about Nalox boxes.
Oh goodness, I wasn't totally prepared to speak to everyone today.
Well, just not formal, just
Well, I'll just say that I really appreciate all the work that everyone is doing. And though we're not totally duplicating the work of All Together, we do a lot of the same work because we do have some similar funding. So one of the things that I put in the chat, as a Drug-Free Communities grantee, we do have the opportunity to attend the coalition. They've renamed themselves, but Coalition America Agency people. I apologize. I'm not going to come up with it. CADCA is the former acronym. And so we get to go potentially twice a year to really learn about what other people are doing around the country. And we had the awesome opportunity of presenting one of our ideas at this last leadership forum in January. And so as you know, the Upper Valley really struggles with how we support adolescents who are already seeing significant risks and issues with substance use. And so we created kind of a team approach of those working at the schools, those working in our recovery center, and trying to figure out how to get kids to the recovery center and make that a place that is comfortable and allows kids to not only see it, but see that there are some askable adults there as well. So that's one of the really cool things that we have put in place this year. As well, we got to see the folks in West Virginia that created this one box. And so you'll see my comment in the chat, and I don't have to reiterate that. But it's a really cool thing, but it's a little expensive. Certainly the idea behind it is that in the moment when you are trying to administer Narcan is not the time to learn how to administer Narcan. And some of us want to do the best that we can in that moment, even if we're not trained. And so the idea is that it literally, you open the box and it starts talking to you with a video right inside. So it could be very useful if we start putting Narcan out and about in our communities. I think I'll stop there. Happy to answer questions if anybody has any. Thank you so much.
Great. Thank you so much, Em. So did anyone have any questions or comments for any of our presenters this morning?
I do, if possible, actually. Hi,
Sure, that's what this space is for.
My name is Nazoni. I'm with Safe Spaces for BIPOC and Allies, which is not exactly, I think, the typical organization joining in this partner program. But I can't help but think that this would be an amazing opportunity to kind of roll this into some of our youth groups. When I think of drug addiction and the experimentation with substance abuse with our youth, I also find that and I'm not sure what the numbers are on this, and I'm sure that there's some statistics that speak to it and address it, but in smaller communities where there's less and less for children to do on their own without having to be brought by parents, but it seems like there's a higher rate of use and experimentation, right? So I'm just wondering if at any point in time youth activities are also being looked at, like what youth have access to on their own. There used to be, the day of having a roller rink or having an arcade or someplace where kids could go to and occupy their time in healthier ways. Not to say that, it solves all the issues, but there has got to be some sort of correlation between what's available to kids after school that is not necessarily an after school, at the school program. That's not for all kids. Just food for thought, I guess.
No, I think that's a great topic to bring up. I I can just say personally, I have a 16-year-old, and I've certainly noticed that when I was a kid, I had a lot of free time to roam the community on my own, and the community, and I wasn't alone. That's just the way we moved. And these days, I really feel like teenagers are programmed up until the moment that they go to sleep. And there are kids for whom that is not the way they're going to live their lives. And so we've left a big gap. Andra?
I was just going to say, immediately when you started talking, Nizoni, I was thinking of how the traditional approach to drug addiction and substance misuse has kind of been challenged by reflecting on the fact that a lot of the studies done on smaller mammals they were in cages with nothing else to do. That it had everything to do with the sort of moral judgment of human beings, and less looking at like, oh, when you actually have like a vibrant community who is addressing your, some systemic issues that may be going on, and things like that, that people actually don't want to be addicted to drugs. Like that's not when there's other, so when they're connected.
For a good case study, there's a small town in Maine called Lubec. I grew up right outside of Lubec. And during the time that I was there, we had an arcade, we had a roller rink. There were activities for kids to do in town, and kids from Cutler, Machias, from up to 50 miles away would all, find their way to Lubec to have these activities to do. And when they took these really youth focused opportunities away and turned them into bars for adults, which was really sad to see. But when that happened, you saw a very definitive a spike in drug abuse, drug use, teen pregnancy, and also a spike in STDs, right? So we were left to find our own ways of entertaining ourselves. And it was a very, very sad thing to see. But I actually think that there's material out there if folks were interested in like kind of seeing how that decline happened and how they're reclaiming it there. So I think they're doing some activities to reclaim it, but being in the middle of that and watching it happen was really, for myself as a teen, very eye-opening. To how the effects of not having anything to do constructively, right, can lead to some really unsavory behaviors and activity. So thank you for allowing me to share.
I'm seeing some folks put things in the chat that relate to this particular topic. And yeah, thank you for bringing this up.
Absolutely. Thank you for allowing me to share.
Yeah. Anyone else? This topic, other topics?
Alice, could I just add one thing about the nalox boxes?
Sure.
So we were recently told by New Hampshire DHHS, the Bureau of Drug and Alcohol Services, that they have purchased a large amount of the nalox boxes. And so those will be made available to organizations, businesses, whoever wants to install one on site. So if anyone is interested, they can connect with me and I can help them work through that process. It'll be free of cost. They are, as Em mentioned, they are quite expensive. It's a different kind than the one you put in the chat, Em, but if anyone wants to install one in a location, feel free to reach out to me and we can get that going.
And Lauren, don't hesitate if you have someone on the fence to send them my way and I can
Absolutely
try to support.
Yes. Thanks.
Martha?
Question about on the nalox boxes, and I may not have been listening quite clearly enough to hear this, but you mentioned organizations and businesses. Are you connecting directly with the community, the municipal health officers or the fast squads in the communities? Do they, like as point organizations in our small towns, are they connected directly with you?
I am not connected to them directly, but if you have suggestions or contacts, I'm happy to reach out to them and just let them know about the opportunity. We have put some Nalox boxes in some municipal buildings like libraries or town halls, so it's definitely an option if they're
Yeah.
interested.
I was just imagining to have that group of people who have, some expertise and see the emergencies would be nice for them to be educated about this.
Yeah, absolutely.
Yeah, Martha, if you don't mind, I'll just piggyback. It's really important that they know where they are.
Yeah.
Too. That we don't just put these things up, without their knowledge and their blessing. So absolutely, I think you're right on track.
And Lauren, that's something I can probably help with in terms of connecting with some of these folks in our communities.
Great. Yes. Thank you.
Good. Between myself and Anna and the emergency preparedness folks in Vermont, I think we can make those connections happen.
Yeah,
Great.
Absolutely.
Excellent. I keep checking to see if Alice Stewart has been able to join us yet, and she's not here. So what I'm going to do is actually move to the next part of the agenda, which has to do with the Community Health Improvement Plan. And then if Alice joins us, we can interrupt what I have to share and go back and let her speak. Any final questions or comments on this whole question of substance use disorder and how it's being addressed in our community? I will also add that I am very proud to be serving on the board of directors of a new program that is being developed here for the Upper Valley, which will be eventually a residential treatment program for pregnant and parenting women, a location where they can actually bring their children with them to be part of their treatment and recovery process. And it's great. We have a lot of wonderful partners here in the Upper Valley. It takes a little time to pull together all the resources that you need in order to renovate a space and get yourself off the ground, but we're still moving it forward. They're in a fundraising phase to do a renovation and build out sort of the startup costs for something like this. And so if anyone wants to ask me more about that particular project, which is called Families Flourish Northeast, please reach out and I'm happy to tell you all that I can or connect you with people who know even more. Okay, so
Alice, can I ask you a quick question, if you don't mind? The Families Flourish, how is that different than Willow Grove Transitional House for women? It's more of a not IOP. It would be more of an inpatient.
It's a residential treatment program, not a transitional housing program.
Thank you very much.
And the goal is to be able to. Yeah, the goal is to be able to serve, I think, 12 to 14 women at any particular time. Okay, so I think, Carolyn, yeah.
Can I ask you a quick question about that? Is that for any time during their pregnancy? Is it for how far postnatal?
How much time postnatal?
Yeah.
That's a great question. I don't think that I can answer it myself without the potential of saying something wrong.
Okay.
But I am going to put the link to the Families Flourish website into the chat for anybody who is interested.
Great. Thank you.
Yes. Great. So I think that except for sort of final endorsement of the Community Health Improvement Plan, I think it's done. So what I'm going to do today is just share with you how it's organized and how I hope that it will be used and useful for folks rather than something that is sort of put on a shelf and we come back 3 years later and start saying, oh shoot, oh shoot, oh shoot, we didn't do these things. So I am going to share my screen, making sure first that I have the right document lined up in the queue. I have shared this as I've been working on it a little bit. So some of it will look familiar. Let's see if I can do the slideshow. I am not going to go into the details of what's in it, but I love the fact that Andrea and Lauren used it as a framework for their presentation. So as I've said before, this is really a summary of the community health improvement efforts that are being planned across the Upper Valley, and there are lots of organizations that are involved. The Public Health Council is engaged in some of this work, and in some of this work, we're not. It's happening within partners in other places. But what we're hoping that this document does is allows folks in the community to see a large part of the work that's going on in the community all in one place. And looking at it from the perspective of, oh, is there something going on in another sub-region of the greater Upper Valley that I really want to know more about or be connected to? Or is there something, am I on the cusp of starting something that maybe is being done in other places? As usual, it's about catalyzing conversation, catalyzing information sharing, and hopefully catalyzing more collaboration across the region. So I have compiled this information from lots of sources, and I appreciate all of the work that many of you have done to take a look at it, to contribute to it, and help us get to this point. What it contains is a summary of what's come out of the various hospital community health needs assessments and their own community health improvement plans. So I'll show you what that looks like in a moment. And then there are briefs for each of the priority areas, which are 7 of them at this point. Then I have some pages that show the strategies by the lead partners that are involved in that work. I want to say very clearly, I know that there are partners that we've left out of this. It's purely an omission of just not knowing that somebody's involved or just sort of missing it. So this is a living document. It can change periodically if folks want to be added or subtracted or things clarified, we can continue to do that. And then there's an indicators catalog and data and baseline data piece to this. And hopefully I will be able to build most of that into a clear impact dashboard over the next few months to make it easier for us to kind of keep track of what it is we're trying to do and how we're going to measure it. And then the last couple of pages does have a listing of all the lead partners. In most cases, it's simply a link to their own website or maybe a description of some of the core work that they're doing. So an introduction, it's an introduction. It's not all that exciting. So, but it tells you a little bit about who we are and why we're doing this work. This is the section where we summarize how this all is driven by the community health needs assessments done by our area hospitals and a few of our visiting nurse associations as well. And then here is where I summarize the priority concerns that were identified across 3 different community health needs assessments. And of course, the DHAPD and VNH did one together. But you'll see that, that there's a tremendous amount of alignment in terms of the issues that showed up in these different areas. And that's allowed us to really focus on a core set of priorities for our region that are reflected in most of these community health needs assessments. And here I have, it's actually 3 pages. I would love to have been able to do it in a smaller chart, but what this does is it lines up the core strategies, probably not all of the strategies in these hospitals' community health improvement plans, but it does line up the ones that align with the priorities that we've established. So you can look here and see, for instance, under questions of the cost of healthcare services, insurance, and dental care, and I know it's tiny, but the point is, you can see what is being done in the 4 different hospital service areas in the region, and get a sense of, you know, what's similar, what's different, what complements each other. And so I hope that this is a helpful tool to see what's happening from the hospital investment side across the region. And then the next section is these briefs per priority area. I have updated a little bit the one that Andrea and Lauren showed earlier, but each page here includes the core indicators that we've established for the priority, the strategies that have been proposed in these buckets: collaboration and service improvement, education, advocacy, and health equity. We've also included a few extracts from the community health needs assessments or focus groups or other sources of information that sort of support and build out the message around why this is such an important issue for the region. I have tried to make these a little more attractive in places. Please forgive my lack of layout and graphic design skills. I'm not going to go through each of these, but you'll see that the format there is the same. And the hope is, you know, that people could actually extract one page and say, we can share this, we can use this as a guide or a tool to tell people what we're trying to do within this particular priority area across our region. So for each of the priority areas, okay, and then because the question of who is doing this work is so important, I have a few pages here, one for each of the priority areas that matches the strategies being proposed with the organizations that are key to that work. Again, I'm certain that there are organizations that should have been on the list that are not, and I'm happy to add those as we move forward. So one for each of these priority areas, you can see who's sort of attached to those. And then we get into the indicators catalog and baseline data. So each of these priorities has at least 2, if not 3 or 4 key indicators that we're going to be tracking over time. There are probably many, many, many more indicators that we could look at. There were suggestions for things that we should add. The difficulty with data indicators like this is that you want to be certain that you have repeatable access to reliable information, particularly on a scale that tells you something about your community. So if all of our indicators were only available at the level of New Hampshire or Vermont, they might not be very useful for work that's going on here in the Upper Valley. So we've tried to find county level data through county health rankings. I know that we do cover part of Orange County, and so there's a possibility that we could also pull the Orange County, Vermont data into this as we move forward. But for the purposes of establishing sort of a baseline sense of where we are, we worked with Grafton and Windsor County, and in a few cases, we did pull in New Hampshire and Vermont data. And as I said, I do hope that I will be able to build out a dashboard for this using Clear Impact that will allow us to show the data over time as we move through the next few years some of these data sources are not available every year or even every 3 to 5 years. And so there will be some that we don't see a lot of change in the period of time for this community health improvement plan. And then here we have the lead partners list. And as you'll see, it has been sorted by the name or the abbreviation as it's been used in the strategies documents for organizations. And then in any case possible, I've added a hyperlink to that organization's website, so it's easier for folks to kind of flip from one to the other and find out who they are. There have also been a couple of cases where I use an abbreviation like FRCs for Family Resource Centers, and then I've listed out which organizations we are referring to with that particular abbreviation or group. The same thing for housing partners, which is a broad statement, and I know that there are many more organizations that are involved in the question of housing work. So I put out here who's very much involved, and I already see that I need to add vital communities to that list. So again, if you see things that really need to change, do let me know. I can do that. But that's the lead partners list. And that's the end of the document. I kept thinking there was more that we could add, but then I thought the principle here was to keep it as simple and straightforward as possible. So, you know, and also to have it be so that it can be useful sort of one page at a time for folks. So anyone, questions, comments, thoughts? Let's chit chat.
I actually can't wait to see it all a hard copy, Alice. You know, it's hard to follow when you're talking through, but as you're talking through, I'm like, oh, that would be really cool. I can't wait to see that page. So thanks. Can't wait to get it.
Yeah, I think it's nicely packaged and nicely presented. So thank you for that.
Great, thank you. I will certainly be loading it onto our website. And actually, I think it's going to be the catalyst for a reworking of our website. Because if you go to the Public Health Council's website right now, there's the priority pages, and the priorities are actually keyed to our last community health improvement plan. So I'm going to have to actually redo the priority pages, and probably will use a lot of the content that's in that document on those pages. So, you know, you'll see the same stuff in the two places, in addition to information about some of the other things that are emerging in the region. So. I think we will make a limited number of hard copies available to folks. When you create something in the format that I did, I'm imagining that the printing costs will be exorbitant, but we will certainly make it available as a PDF and in a variety of ways so that people can use it as they see fit. I'm seeing warm responses in the chat, so thank you. Eric?
Hi, Alice. Eric Harbeck. I'm from Headrest. I'm actually a returning staff member.
Welcome back.
Yeah, thank you. Very grateful to be here. Certainly Headrest, because we operate, you know, a few different, you know, programs, most notably our hotline. We would certainly love to be partners and to have any resources, because the audience that we serve is pretty widespread. You know, from operating the 988 hotline and our own local hotline. Any of these resources we'll put in our guidebook and continue to share with anybody that calls. So, and then in addition to that, with our residential and our outpatient programs, certainly love to have any material that we can share with people.
Great, thank you. Anyone else? Good. So as I said earlier, now that we have this and we sort of have the strategies and the partners, the key partners laid out, I do hope in upcoming Public Health Council meetings to focus on sort of one priority at a time for each meeting and pull together a group of folks that can present on the work that they're doing as it's reflected in that, or other new and emerging things. This is not closing the door on us talking about other things as they emerge in the region. So if any of you have ideas about ways that we can sort of pull together people to present on a topic at a Public Health Council meeting, please feel free to reach out to me. I work best by getting good ideas and working with other folks to make things meet your needs as we do this pulling together. Oh, and I also want to say, now that we have that list of lead key partners, we have the partner page for the Public Health Council website, but it hasn't been updated in a very long time. I'm actually hoping to sort of make sure that we can list all of those folks on the Public Health Council's website to reflect the fact that they're all involved in this work. So if I reach out to you at any time to just confirm that you can be listed there, please respond. We'd love to reflect all of the great work that's going on in the region. So let me see, Alice Stewart, have you been able to join us yet? Okay, well then we can spend a little time on general sharing from members and folks who are here before we wrap up the meeting today. Does anyone have anything that they would like to let others know about? I also always like to say, this is a good space to present challenges you're facing, things that, and because we are a very multidisciplinary group of folks, it's a great opportunity to hear from other people with different perspectives on what your particular challenge might be and get new information and new ideas. So share, ask, this is your time.
If I may, Alice, I know I'm a newbie here, so I apologize for taking the limelight. But it's just been, since returning to Headrest, it's been such a wonderful experience. Obviously, I wouldn't have come back if I didn't love it here. In February, Headrest became the primary call center again for 988, meaning that anybody with the area code of a 603 number would get primarily redirected to the Headrest call center. And for those who don't know, Headrest does have the ability to make warm handoffs to the rapid response access point to where they would then dispatch a mobile crisis team to that individual if that was needed. So if you work with anybody or a population of people who are in acute crisis and need that immediate support, 988 is the way to go, and we'll be there for them. And we can certainly refer them to more substantial supports if needed. In addition to that, Headrest has also hired a new executive director, Judy Caprio. She unfortunately is living in another state right now, but will be moving here within about a month. And we are delighted and excited for her move to New Hampshire. And I just wanted to let everybody know that information, because I imagine she'll make the rounds to get to know all the partners here and learn a little bit more about what work we're doing.
Great, Eric. Thank you for your information. It's great to hear about the 988 role that you're playing, and that Judy will be coming on board. Please make sure that her email address gets to me, because I think that being a part of this mailing list and this group is a great way to quickly get to know lots of different partners in the region. So we look forward to welcoming her. Perfect. Anyone else? Oh, Eric, I was going to ask you a question. I'm sorry. One of the challenges that we've talked about here in the Upper Valley is the fact that so many people are by state, and the 988 system is not really good at understanding the New Hampshire-Vermont split. And I'm wondering if you can comment a little bit about how calls coming in might be handled. And I've even heard that it can be like your cell phone, where you are, sort of affects whether it goes to a New Hampshire or a Vermont center, and it may not actually line up with where you're located or living at the time.
Yeah, so the routing system through Vibrant, who's like kind of the umbrella, they're the architect of the call system. The primary center that you're routed to would be whatever center your area code is associated with. So if I live in California and I call from a 603 cell phone, I will go to the New Hampshire call center. However, if that center is busy, you'll get redirected to the next available center. It just happens to be that Headrest has a relationship with the state of Vermont, and we are the primary backup call center for the state of Vermont, because the call center in Vermont only operates, I think it's Monday through Saturday, and it's limited hours. And we, on average, I think receive about close to 200 calls a month from Vermont residents, not including from our local 4400 number. So that's just specific to 988.
Thank you for that. That's helpful information. I know it's this is nothing to do with you. I think it's kind of sad that in this day and age of rapid technology development, that a system is built that routes people to a service based on their area code, when so many people are just carrying their cell phones with them wherever they live. And the area code really, in most cases, means nothing anymore relative to where people are located. So behind the times a little bit, I suppose. Martha?
Click the hand and not the mute button. Sorry about that. Huge thanks for that for the update on the helpline. And I think it's really comforting for folks in the Upper Valley to know that's actually kind of a local number, which is where so often isn't the case with those big helpline numbers. We get routed out of the Upper Valley. So that's really great to know. I was hoping to just bring a quick note about the Upper Valley refugee and asylum seeking welcome work. I've talked about it briefly over the course of the last year and a half or so. I've been directly involved with the Upper Valley Neighborhood Support Team, directly affiliated with Accentria Care Alliance, which is one of the New Hampshire State Refugee Association. There's another organization called SHARE, which has been involved primarily with asylum seekers, but also refugees, also scrambling in the last year and a half to welcome quite an influx of folks. And right now, we're working very hard to collaborate and coordinate these efforts into something that will seem simpler for folks who are trying to find us. But the bottom line is that we have all along, and we continue to be really trying to welcome anybody and to embrace and support anybody. It doesn't matter if they officially came through a service. There are a lot of folks who are here as refugees that came straight through with their sponsors, particularly Ukrainian. So they're living with families all over. We're happy to help however we can. So I personally can be a contact. I'm working, with part of the team that's trying to figure out how to pull this better together and organize it. I mentioned to this group specifically, though, that it's really necessary for this work to involve partnerships with organizations that are set up to be helpful and provide services to people who are new in the community and to support that. So And I can also tell you that we don't yet have a really super way for you to just go to the website and sign up and we'll have the perfect relationship. So we're trying to work with partners. And if you are specifically trying to welcome refugees and asylum seekers or others who are new to the community, we love to talk with you if you have time to try to build what those relationships might look like. And there are a few of you that I'm specifically thinking would be, I see you smiling, Sarah. It would be really nice for us to figure out how we can be most helpful to one another. In the previous conversation at the Elder Forum, which some of you were at, I also mentioned, how do we connect with community groups? And I think this is just another one of the many ways that we need to do that work together. One thing specifically I wanted to mention is that on the sort of health side of the welcoming front, we had a Dartmouth medical student who worked with us in kind of a medical accompaniment model with one of the gentlemen who had particular needs. He had a surgery he had to go through and some follow-up. And her experience with us working with kind of a community group of health navigators, friends, and folks who are trying to pull that together, encouraged her to apply for a Schweitzer Fellowship through the medical schools, which she actually just received. So through her work, she's going to be building out this medical accompaniment model, engaging more Dartmouth or Geisel medical students in working with refugees and asylum seekers. Key to that is going to be their partnership with kind of a set of community health navigators, community organizations, and a few of us at the core of that. If you've got that sort of medical or system connection and you'd like to be a part of that, contact me directly. I'll put my email in the chat, because we'd love to put a little committee together that's helping that team coordinate services. Thank you. That's a lot of things. Thanks very much.
Sounds great. Thank you. Martha, I would love to put that into the notes that I took. If you're able to send me a quick email with sort of some detail, a little more detail, because I'm not sure we captured enough of the information, that would be super. Maybe links or something. That would be great. Thank you. Alice,
not yet
Stewart?
links, just for
Pardon?
folks to not yet links.
Okay, that's fine.
To understand. It's potential conversations, hopefully at the moment.
Perfect.
Link soon. Great.
Okay, so Alice Stewart has joined us and can talk a little bit about what's going on with substance use disorder work at Mount Ascutney Hospital and Health Center. And so I am going to put the slides up for her. There are only a couple, and then let her tell us what's going on.
Thanks, Alice. So I'm just going to apologize. I have a laptop with a non-working camera and a not very good microphone, so I hope everybody can hear me. Anyway, the wonders of technology. Also, I saw these slides for the first time about 8 minutes ago, so I'm going to do my best. We're, small hospital, wearing lots of hats. Melanie wasn't able to be here, and these are her slides. So these, the two slides that we're going to look at really quickly are the dashboard slides for our Windsor Health Service Area Community Collaborative, which is basically the accountable community for health that Mount Ascutney coordinates. Data points that they're tracking are the opioid fatalities. Windsor continues to struggle with being, one of the counties that has one of the highest rates of opioid fatalities in the state of Vermont. So you can sort of see those, that's what those numbers there are tracking, the number of fatalities, and we're at the third highest rate. One of the things that we are doing, that we've been doing for quite a while, is the recovery coaches in the ED, the emergency department. And so there's some data there where you can see the types of substances that the recovery coaches are engaging with people around, alcohol being the largest number, followed by opioids. Excuse me. So we provide funding to both the Springfield and the Hartford Turning Point centers to do this recovery coach work. So there's recovery coaches in the ED, and then they also do outreach after overdose work. We're providing them with grant funding to do that. I know just one thing I do actually know from looking at their progress reports from their grants is that both centers have been feeling a little, I don't think struggling is the right word, but that recovery, the outreach after overdose has been getting a little bit harder. So I think that's something we're going to be digging into a little bit going forward. We also do medication-assisted treatment in the ED with direct referral to the Connecticut Valley Addiction Recovery for rapid follow-up. In November 2022, we started a clinical pathway to admit patients to the hospital if they qualified for medically necessary detox. So we're trying some new things. And then I think, do you want to go to the next slide, Alice? These slides have a lot in them because they're designed for the HSA meeting. So, absolutely, people feel free to dig into them later. And if you have questions about things, I'll put Melanie's email in the chat when I'm done talking, because Melanie really would be the better person to ask questions, although I will try to field questions today if people have them. You can see we're also tracking our administration of Narcan, expert screening for new patients, which looks like it's going down. So I'm guessing that the community collaborative will be looking at that to see what can happen to move that up. I do know, even though I mentioned that the recovery, the outreach after overdose, they're feeling a little frustrated by it. I do know that they've had a couple of really successful cases, so that, it is a very, each person individually, they're small wins, but they're big wins for those individuals and their families. So I know that the coaches are really very dedicated to that work. Actually, I'm going to try to do a quick screen share. I don't know if everybody's seen the We Are Worthwhile campaign. And actually, of course, I just realized I'm on the wrong screen. So give me 1 second.
I had stopped sharing so that you can share your own stuff.
Great, thanks. I just need to get to the right thing here. I think with all these sharing things, it would be so easy now, and yet it never is. So for anybody who's not familiar with it, this We Are Worthwhile campaign is something that we've been working on with the Turning Point centers, and it's really a lovely campaign. These are actual individual people. Some of them work at the recovery centers. We've been doing, you might have seen some of these on the side of the advanced transit buses. There are social media posts. There are different types of swag, really trying to get people through different channels to engage in recovery. So if you're not familiar with the site, I'd highly recommend you take a look at it. And if you want any We Are Worthwhile things, we have, I don't know, all kinds of things, pens, bags, all kinds of things. So if anybody wants anything, once again, let us know, and that's something we can get to you. When I put Melanie's email in the chat, I'll put mine in there as well. And then the other thing that Melanie wants to let everybody know is that our community health improvement work group, the Windsor County Substance Use Disorder Collaborative, meets every month, and anybody's welcome to join. And that group meets on the 4th Wednesday of every month from 9 to 10:30. So another name and email that I'll put in the chat is Anna Urea, who's our CDC Public Health Associate who supports all of our community health improvement work groups. And those are all the talking points Melanie had. We are obviously still doing all of our prevention work. M. Zanleone and I have been working on a cannabis and pets flyer, which is in my office now. There are 500 of them in my office now, so we can start taking them out to the cannabis retailers and to the local veterinarians. We're really working, for some reason, people just don't get as focused on the cannabis and kids piece. And so we're hoping by focusing on cannabis and pets that we will actually also be protecting children from accidental poisoning and exposure to cannabis products, especially edibles. So anyway, that's all I really had to share. So if anybody has any questions, let me know. And otherwise, I'll just pop all those emails in the chat.
Thank you, Alice. That was a lot of information, and you guys are clearly doing really terrific work. Anyone have any questions for Alice or additions in information? Definitely saw faces paying attention. So, and I love the look of the Worthwhile campaign. So with your permission, I will send those slides out with the summary of this meeting as well, so people can see that detail and and get back to you if there are any other questions.
Absolutely.
And I have to say, it's hard to read the chat and see people referring to Alice. And I know that it's Alice Stewart in this case, but I keep thinking, oh, they're saying something to me. Okay, so any other information that folks want to share or challenges that folks want to mention?
Oh, sorry, Martha, you raised your hand. You go first.
This is actually a super naive question, and I just if someone can answer quickly, that would be great. If someone needs to contact me directly, with Mental Health Awareness Month coming up in May, one of the things that Community Care of Lyme is doing, we're just putting our programming and trying to get all the different angles on that. And I'm wondering about the mental health connection between substance use disorder and like where we're correct to be talking about substance use disorder or some of the other the things that we're just talking about recovery. How do we think about that linking with, you know, mental health? Is that a fair question, or do you understand my question?
Martha, could I piggyback on that? So I just put in the chat our really quick flyer about our mental health first aid offerings. So all three of us now we're all three part-time employees at the Hartford Community Coalition, but we know very well that substance use doesn't start necessarily with boredom or nothing else to do. It really starts because we have a hard time dealing with our big feelings. And Kelly and I have an awesome time going into school classrooms and teaching teen mental health first aid. We also can teach adults the youth mental health first aid model, which is for people who are working with, care about youth. And then I just recently got trained in the mental health first aid version. So we can now train the gamut of people who could be essentially first responders around mental health crisis or concerns. It doesn't necessarily hit all of those points that you were just talking about, Martha, because those who are deep in addiction need way more than first aid. But it's a start, and it's definitely a start for our youth, which is our main focus over here at HCC. So please feel free to reach out to us if you want to bring a training. They're about 6 to 7 hours long. We can do them over days, we can do them over a couple of periods of time, but it is a pretty intense training, but very brief kind of, sorry about the cat, interaction with the material, a lot like CPR. You're not trained to be a doctor, you're trained to be a first responder. So there's that. And then I also put in the chat, we have a robust summer meals program that we have been running now at HCC well before we became a nonprofit organization. We've been running for our schools, both in Lebanon and Hartford. And HCC has taken on the burden of organizing and managing those programs. With all of the new restrictions that are coming from the state and federal levels, I could really use some help in managing that program. If you know someone, even if they're a retired someone who just wants to help, but they're kind of type A personality who can keep me organized, keep us moving through all of the check boxes and crossing our T's, that would be awesome. And for me, that would be a fairly priceless gift. So I'm totally willing to work with someone around flexibility of time and payment because it almost drove me into a spiral last summer. So the more hands on deck would be great. So if you know anyone, please reach out to me. Thanks a ton, everybody.
Thank you. Anything else anyone wants to share or ask? Lori.
Thank you, Alice. So, I just have a question about the mental health first aid. It's great that you're offering that program. West Central did it for a long time, and people who took it really loved it and got a lot out of it. So I'm just wondering if there's a charge for that program.
No, there is no charge. The only charge that comes for us is the manuals. But if we're doing it in New Hampshire, the UNH Extension got a grant to train a bunch of people in this model. And so they actually will pretty much cover everything. And then for those of us on the Vermont side, they've been pretty generous too in covering most of that. The manuals that everybody receives is about $25 a piece. So essentially you kind of get everybody there with the idea that this is about $25 of our resources, say nothing about our time getting a training together. But no, we don't need to charge at all. We can make that happen through UNH or through HCC or All Together, because All Together also has a couple of folks that are youth mental health first aid trained.
So what is the primary contact number or email address for people who might be interested?
Yeah, sure. I'll put that in the chat, Lori, if that's okay. And everybody will have it. Fabuloso. Thank you, ton. Thanks for the questions.
I also just put in the chat, Lori, that Andrea and I can be contacts in New Hampshire for the youth mental health first aid. We're both trained to facilitate that. And then we have colleagues who serve in the Greater Sullivan County area that are trained in the adult mental health first aid. And more of us are getting trained in both of those. So feel free to reach out to myself or Andrea and we can organize something or connect where needed.
Thank you, Lauren. Don't you think if we got enough people trained in mental health first aid and then offered volunteers to the senior center, that maybe we might be able to do something about the depression that older adults are suffering? That perhaps we could make a difference if we had enough people trained in that.
That's a terrific idea, Lori.
I also learned recently from the coordinator of the mental health first aid trainings in New Hampshire through UNH Extension that they also just got more funding. I believe it's a few years worth of funding to specifically focus on older adult mental health in rural parts of the state. So that sort of niche training will be coming, I believe.
Lauren, that's great. So one of the reasons I mentioned older adults is because I hear from the community nurses all the time, the number of their clients that are not getting out and how depressed and discouraged people are. So if there was a go-to location where people who had that certification might sign up, maybe people could make some visits. Maybe through you, Lauren.
You know, it's possible that it might be something like Lauren, but I also think if there's already an organization out there that manages and deploys volunteers, then maybe that's a piece that could be added to the work that they can do, as opposed to creating a new volunteer management structure within an organization that doesn't really do that. So it becomes more sustainable. So that may be a question as to what's out there in terms of organizations that manage and deploy volunteers. And then as you put people through the mental health first aid training of any sort, you sort of say, you know, are you willing to now use this as a volunteer support person in particular settings? Could we, you know, try to connect you with folks that are looking for this, like the senior centers, as you're describing?
That's
yeah,
ideal.
I think that's, pardon?
I think that's ideal. I only said Lauren because I wasn't quite sure we don't really have that resource yet here in the Upper Valley. That could be sort of a generic point where volunteers could be referred, and then there could be an opportunity or a way of making those services available. So otherwise, it's great.
Yeah. Okay.
I wonder if it's even encouraging folks who take the course just to kind of register with their local fast squad, or just like to let people know, even if they're not ready to commit to some formal ongoing volunteer effort, but just, I mean, they must have done it for, maybe some of them do it, I know, for their own personal reasons, but if they're willing to just let folks know, that would be also like a step in between full sign up for volunteer work.
Yeah.
Community nurse just needs to find them.
Exactly. That's what, yeah, exactly. Community nurses or fast squad. Yeah, exactly.
Great. Perfect. Thank you. Anyone else have any information they want to share? Okay, I'm not gonna let the silence hang forever. Thank you all so much. I hope this was a good meeting for all of you. If you have any thoughts, suggestions, or feedback, please feel free to send me an email. I do want to let you know that our next partner meeting is on May 19th, 9 to 11 at least. We are actually hoping to schedule this in person again. I have to find a location, so not there quite yet, but please do hold the date and time and make a little note in your schedule that it might actually be in person. So don't schedule something to start at 11 a.m. No back-to-back Zoom meetings, perhaps at that time. And if I find the right location, we may actually invite people to come and join us for a breakfast beforehand, because I know it's been a long time since some of us have been in the same space. Yes, Carolyn.
Will there be a virtual option for May 19th, or is it going to be either in person or virtual?
The preference, my preference, and the preference of other folks that I talk to is that it's, with a big meeting like that, it can be very challenging to do hybrid, and also challenging to find a location that allows you to do hybrid with that technology. So it's very possible that it will be in person only, and not a hybrid.
If you do a hybrid, can we chat offline as to the process and such? Because there's a couple meetings that I hold that I would like to be hybrid, but like you said, there's a lot of challenges involved.
Okay, so you're hoping to learn from me?
I am.
Oh boy, you're in trouble.
I am.
Great, thank you, Carolyn. Yes, certainly.
Thanks, Alice.
Okay, and then after that, our next meeting is June 16th. I say this because we don't meet every single month. And I like to remind folks of that. The meeting schedule is on the Public Health Council's website. So if you need to double check when we're meeting, I'll be there. I do try to get the meeting details onto the website sometimes. And I think this month I may not have done that. So if you're not finding the information you need about when and where the meetings are going to be, shoot me an email, and that might prompt me to get the information out to folks. And if anybody has any final comments, please feel free. Yes.
Hi, Alice. It's Barbara. What are your plans for the format for the June meeting? Would that be in person or virtual?
I don't have an answer to that yet. Is there a preference? I think
I have a preference, but I'm not going to speak for the whole group.
Okay. I think the idea is that it would be lovely if we could do things in person over the summer when there's a little more, possibility of airing things out and the virus is less present in the community. But I do want to see, for instance, if nobody comes to May because they're not ready for that, then we would want to go back to the Zoom option. All right. Well, thank you all so much for joining us today. Lots of great information, and I will get the summary out to folks as early next week as I can, and look forward to seeing you around soon. Take care.
Thanks, Alice.
Thank you.
Thank you.